Hi, I'm David Landwehr, an endodontist at Capital Endodontics in Madison, Wisconsin. As a dual-trained oral and maxillofacial pathologist and endodontist, I often get asked by my referring colleagues to consult on cases when the endodontic diagnosis is not clear. As a result, I see several cases a year where the radiographic and clinical findings don't confirm the diagnosis. Over the next several minutes, I would like to describe some clinical scenarios that suggest a referral is in the patient's best interest. For example, when the preoperative and postoperative findings don't agree. This really isn't a worry for me if I'm debating between the diagnosis of an irreversible pulpitis and a necrotic pulp. However, it is definitely an issue if there is a periapical radiolucency and a vital, healthy appearing dental pulp is discovered in the chamber. This suggests the radiolucency is not due to a pulpal origin, but is more likely due to a non-inflammatory etiology and may be neoplastic. If the patient has pain as a complaint prior to the root canal, a 1 to 2 week recheck to determine if the pain has subsided would be a reasonable first course of action. However, referral to an oral and maxillofacial surgeon for biopsy to determine the exact etiology of the radiolucency would be the most prudent course of action, especially if symptoms are unchanged following the root canal treatment. Atypical or aggressive clinical behavior is another indication for referral. Significant bone destruction with resorption of the roots suggests a possible non-inflammatory etiology, and referral for further diagnostic workup would be a good idea. This is an example of an osteomyelitis that presented 1 year following root canal treatment. This look is not typical of a failing root canal, and lymphoma, metastatic disease, and a primary malignancy were also considered in the differential diagnosis. Inconclusive clinical findings and pulp testing may also suggest a referral. If a patient has pain as a chief complaint, and the pain doesn't have the typical triggers that suggest an endodontic issue, like cold and heat sensitivity, pressure or biting sensitivity, then my concern for a non-dental etiology begins to rise. My level of concern is further elevated if the dental history and pulp testing are not consistent with an endodontic cause. This is an example of temporal arteritis in a 70-year-old female with the chief complaint of increasing pain when chewing. The pulp testing with cold did not identify a culprit tooth, and there was no percussion or tooth sensitivity to reproduce her chewing symptoms. There was no indication of an occlusal issue, and there was slight tenderness to palpation of the temporal area and the superior attachment of the masseter muscle. The radiology findings were not diagnostic, as the periapical films and the CBCT did not reveal any changes consistent with a bacterial cause. As a result, the clinical findings did not confirm a dental cause, and the patient was referred to her medical doctor. A simple blood test indicated an elevated erythrocyte sedimentation rate consistent with the diagnosis of temporal arteritis. A timely diagnosis is critical in this disease because blindness may result if left untreated, and in rare instances it can be fatal. Multilocular radiolucencies are a reason for immediate referral. Periapical cysts and granulomas are most often several millimeters in diameter and are either well or poorly defined radiographically. They can get larger. It is not unheard of to have a periapical cyst of more than 2 centimeters in some cases. However, even in the largest periapical cysts, the growth pattern should be unilocular. If there is a multilocular radiolucency, the lesion should be considered non-inflammatory until proven otherwise. Referral for further radiographic evaluation to an oral and maxillofacial radiologist would be a reasonable first step. However, referral to an oral surgeon for biopsy would be another possible course of action. In some cases, the radiographic findings will be suggestive of a systemic disease. That doesn't mean that a patient in pain doesn't have an endodontic etiology, but before endodontic treatment is initiated, I will discuss the findings with the patient to ensure appropriate follow-up and management. Here's an endodontic case that I treated several years ago for a necrotic tooth number 30. The pulp testing indicated necrosis, and this was confirmed at the time of treatment. The canals were disinfected and sealed without complication. The patient presented for a routine 6-month follow-up and was asymptomatic with no history of pain. However, radiographic examination revealed a symmetrical widening of the periodontal ligament spaces associated with multiple teeth. This finding is consistent with systemic sclerosis, and the patient was referred to his medical doctor and the diagnosis was confirmed. Other systemic conditions that could be identified by radiographic examination include, but are no means limited to, Gardner syndrome with multiple osteomas, Paget's disease of bone with a cotton wool appearance, or fibrous dysplasia with a ground glass trabecular pattern. I have shown several case examples where referral for further diagnosis and management is indicated. From my perspective, the treatment of some of the pathologies we encounter will require a team approach, and I think it is important to remember that not all radiolucencies that present at the apex of a tooth are endodontic in origin. It is important that the clinical findings and chief complaint are supported by the dental history and pulp testing. When this is not the case, it is important to consider a non-pulpal etiology and referral may be indicated.